Welcome. In this session, we'll discuss the corticospinal tract, perhaps the most important tract that we will encounter in the nervous system. The corticospinal tract is one of many structures that are involved in movement. We see here on this lateral view of the brain, in red, the corticospinal tract originating in the cortex, in the frontal lobe, in the posterior portion of the frontal lobe, with its cell bodies in the primary motor cortex, also known as the precentral gyrus. We see a number of other structures, including the basal ganglia, here in golden color, distributed group of structures. We also see a number of structures that travel down from the brain to the spinal cord, including the rubrospinal tract and the reticulospinal tract, which has two origins within the brainstem, the vestibulospinal tract, which travels down to the brainstem, and we also see the cerebellum, which sends fibers up to the cortex as well as to the brainstem. We'll be concentrating on this pathway for today's session, the corticospinal tract, as it travels down through the brain and then down to the bottom of the brainstem, at which point it will travel over to the other side of the brainstem to arrive at the spinal cord on the opposite side, and we will end up seeing it in the spinal cord, seen over here in cross-section through the spinal cord, occupying a position in the lateral funiculus. If we look at a frontal section or a coronal section through the brain, we can see the origin of the corticospinal tract in the cell bodies of the cerebral cortex, with the leg area represented close to the midline, the arm area more laterally, and the face area most laterally. Those fibers, those neurons send their axons, continuous axons, down through the white matter of the brain, through the brainstem, and then at the bottom of the brainstem, at the spino-medullary junction, they decussate. That is, those same fibers uninterruptedly cross over to the opposite side, and they occupy the position in the lateral funiculus that we see right here. Those cells then, axons, travel down through this corticospinal pathway until they reach their origin, and different axons will peel off at different levels of the spinal cord. And when they peel off, they will send their axons into the gray matter of the spinal cord, synapse on lower motor neurons, and those lower motor neurons will send their axons out through the ventral root to a muscle and be able to cause contraction. If we look at the variety of sections through the spinal cord at the cervical, thoracic, lumbar, and sacral levels, we'll see that the corticospinal tract is occupying the same position in all of those sections, having crossed over from the opposite side previously at the spino-medullary junction, and it will stay in the same position in this lateral funiculus. And again, axons will peel off to synapse at the appropriate level, in the cervical level, in order to control movement of muscles in the hand and arm, in the thoracic levels in order to control muscles in the trunk, at the lumbar level in order to control muscles in the legs, and at the sacral level in order to control lower muscles. The neurons in that upper motor neuron coming from the cortex tend to drive these lower motor neurons in an excitatory way, particularly those that are flexor motor neurons that will cause flexion of the limb at the joint. Now, if there is damage to that upper motor neuron that is damage to the corticospinal tract. It may be in the cell bodies of the cortex, or it could be anywhere along the pathway that those axons travel, in the brain, brainstem, or in the spinal cord itself. If there's damage to any of those regions, there might be an acute effect, in which we call spinal shock, in which there is flaccid paralysis. In flaccid paralysis, the muscles have low tone, and then there is no response. There's low tone, known as hypotonia, and there are decreased reflexes. This is essentially the same. These findings are essentially the same as the effect of having damage to the lower motor neuron. But over a period of time, days to weeks, we'll see a chronic state, and that chronic state is dramatically different. We'll see what we call a spastic paralysis, or paresis. Paralysis is total loss of motor strength. Paresis is a weakness. This paralysis paresis is a difficulty performing skilled movements, voluntary movements. That term spastic is different from the commonplace term spastic. It means that there are increased reflexes, there's resistance to passive movement, and one of the manifestations of that is hyperreflexia. That is exaggerated or increased deep-tended reflexes at any location below the point of damage to the corticospinal tract. So if the damage is in the cervical cord, then the knee jerk would be influenced, and there would be increased reflex for the knee jerk. Over a period of time of continuous hyperreflexia, in that very same distribution, you'll start to see contractures of tendons, and you'll see increasing spasticity, increasing tone, and resistance to passive movement associated with that hyperreflexive state. That hyperreflexia may be manifested with clonus, an extreme form, in which you see alternating flexion and extension of the reflex. There is also hypertonia, and that is this resistance to passive movement. These effects of hyperreflexia and hypertonia are much exaggerated when you try to move the limb quickly as opposed to moving it slowly. So it is a rate-dependent resistance. Also seen following damage to the corticospinal tract is a Babinski sign. The Babinski sign is a sign in the foot in which, when you stroke the sole of the foot from the heel to the toe, you produce an upgoing toe, the big toe, and fanning out of the other toes. Plantar flexion, that is, the big toe going down, is a normal response. It is normal for a child less than 2 years of age to exhibit a Babinski sign. The Babinski sign is demonstrated in this YouTube video. Take the time to take a look at it and observe how it's produced and what it looks like. An upward going toe, that is a Babinski sign, provides very strong evidence of corticospinal damage. And then finally, as a result of damage to this corticospinal tract, there will gradually be a loss of muscle mass, that is, atrophy due to disuse. The lower motor neuron lesion may be involving damage to the ventral horn motor neuron at the cell body, to the axons of that lower motor neuron, either in the ventral root, in the spinal nerve, or in the peripheral nerve. For cranial nerve motor neurons, or their axons, there may be similar damage up in the brainstem or in the cranial nerves. The patient presentation in this setting is acutely and chronically several similar features, but we'll start out with the acute feature, and that is there'll be flaccid paralysis. There's no activation of muscle fibers. There's hypotonia, that is decreased resistance to passive movement. Hyporeflexia, that is the normal knee, if it's at this particular level. It would be decreased reflex on the knee jerk if it's at the lumbar level. It might be at the biceps if it's at the cervical 6 level. But there'll also be other findings, fasciculations and fibrillations. Fasciculations are clinical manifestation of fibrillation in which there are movement of muscles in a random way under the skin, and it will last for a number of days to weeks. The fibrillations may be observed if you utilize an electromyogram with a needle in the muscle, and it's an asynchronization of the muscle fibers that shows that with denervation of those muscle fibers, they generate additional acetylcholine receptors, and those receptors become responsive to any acetylcholine that is released presynaptically, even if it's not under a controlled situation. And as a result, muscle fibers will fire intermittently and manifest these fibrillation potentials in the postsynaptic portion of the muscle. On a chronic basis, we'll also see flaccid paralysis, hypotonia, and hyporeflexia, so that the acute and the chronic feature are quite similar in terms of this paralysis, hypotonia, and hyporeflexia. But in addition, because there is damage to the lower motor neuron, there is no activation of the muscle. There is a very severe atrophy, much more severe generally than seen with upper motor neuron lesions. And that implies that the denervation results in the loss of some trophic factors that are provided to the muscle by the nerve. We'd like to look at the knee jerk as an example of deep tendon reflex and recognize what the features are that are responsible for that. And similar reflexes are seen both at other joints in the arms and legs. And seen here are the features that are responsive. And that is if you tap the patella tendon, you stretch the quadricep muscle. In stretching that, you stretch the muscle spindle. That activates the muscle spindle, sends axons to the dorsal root. The axons come into the dorsal horn. Synapse on the lower motor neuron that goes out to the very same muscle activates that lower motor neuron in an excitatory way and produces contraction of the quadriceps muscle. That's the stretch reflex. Damage to any portion of this pathway, the receptor, the afferent neuron, the spinal cord at this level, that's at the L2 to L4 level, or to the lower motor neuron, to the root, or at the neuromuscular junction at any point would reduce the reflex, would produce hyporeflexia. Recognize something else, and that is, in addition to activating in an excitatory way, this receptor comes in and activates in an excitatory way the lower motor neuron to the same muscle. It also activates an inhibitory interneuron. That inhibitory interneuron, it's an excitatory at this point, it inhibits a motor neuron that travels to the antagonistic muscle at the joint, that is to the hamstring muscle, so that when the quadriceps is contracted, the hamstring will not be activated, be relaxed, because this lower motor neuron has been inhibited. That inhibitory interneuron exists on all of the lower motor neurons from antagonistic muscles. So there are reciprocal effects between both the hamstrings and the quadriceps in each location, on each side, and at different levels of the spinal cord. We refer again to the spinal level dermatomal map and the deep tendon reflexes that occur at these various levels. And I'd like you to use this as a continuing cue card that you recognize that at particular levels, not only do we have the distribution of dermatomes over the cervical, thoracic, lumbar and sacral levels and get to know these levels, the dermatomal representation, but in particular get to know the bicep localization at each level, both the cervical cord as well as the lumbar cord, as well as the muscles that are influenced by segments in the sacral region. Spinal cord lesions, that is those below the spinal medullary junction, produce ipsilateral upper and lower or lower motor neuron signs. And the specific location within the cord, whether it's in the cervical, thoracic, or lumbar cord, will determine the part of the body that's affected. That's a few words, but the impact of that in your ability to interpret this will become very useful to you as we go forward. For instance, a lesion affecting the ventral horn right here at the cervical level, C5 for instance, would produce weakness in the left arm, if we're looking at the left side here, and a decreased biceps reflex that's dependent on the motor neuron and its activation by the sensory. So we'd have a decreased reflex, hyporeflexia. Now, if we took that lesion and extended it, as we see over here, a lesion affected the ventral horn, but also the corticospinal tract nearby, what would happen? We'd have the same deficit for the arm, and that is a reduced bicep reflex, a decreased bicep reflex in the left arm. But what about the leg? Now, the corticospinal tract sitting over here is heading down to the lumbar cord, where it will attempt to activate motor neurons in the lumbar cord. But if those neurons are injured right here, if the axons are injured right here, there is no input to that lower motor neuron for the leg. As a result, that leg will show an increased knee-jerk reflex on the very same side. It would also, because of damage to the corticospinal tract, produce a Babinski sign on the left. In contrast to all of these effects at the spinal cord level, which are ipsilateral, that is, the reflexes and the weakness are ipsilateral to the side of damage of corticospinal tract or lower motor neuron. If we were above the spinal medullary junction, that is in the brain or the brainstem, then the corticospinal upper motor neuron signs, that is damage to the cortex, will have an opposite effect on spinal reflexes. That is, all the damage to the corticospinal tract in the brain on the right-hand side will produce hyperreflexia on the left-hand side and weakness on the left-hand side. That is contralateral to the site of damage in the corticospinal tract above the spinal medullary junction. So we've reviewed a number of these objectives. If you have any question, don't hesitate to call me and we can discuss those. Do review these reflexes in YouTube to get familiar with what they look like as we go forward. We'll utilize those. Thank you.